Record. Okay, so good evening and welcome everyone. This is Maryse Frangier, the Director of CEDAW of Lebanon Fertility Care Center, and I'm the NFP coordinator for the Upper Key of St. Marin of Brooklyn. I welcome all of you to this series of talks that we are concluding tonight with Dr. Angela Kristen, which we started 3 weeks ago. And we are so happy to have Dr. Angela Kristen joining us today. Before we have opening prayer with the Co-Bishop Don Sawyer and I introduce our speaker, I just want to welcome the organization directors who have helped to sponsor and put together this series of talk. And Oleg from Fertility Care Center of Rochester, New York, and the Gianna Education Program, who was our speaker the first night 2 weeks ago. Linda George, the director of the Office of Family and Sanctity of Life for the Upper Key of St. Marin. Subdeacon, I think he's not with us yet. Probably their service is going on in their parish, but I will still acknowledge him. Subdeacon Ernest and his wife Elise Karam, who are the director of the Family Life Ministry for the Upper Key of Our Lady of Lebanon, Los Angeles. And we thank Bishop Gregory and Bishop Zaidan for sponsoring and wanting to help us with supporting this series of talk. Before we move on, Monsignor Co-Bishop Don Sawyer, thank you so much for being with us tonight and opening us in prayer. So please, can you get us started with opening prayer, and then I'll introduce Dr. Angela.
All righty. Okay. In the name of the Father, the Son, and the Holy Spirit. Amen. Heavenly Father, you created man and woman in beauty and dignity by making them in your image and likeness. However, they misused their gift of free will and chose to disobey you. They kept their image, but lost their likeness to you. However, out of love, your Son became man to restore us all into your likeness. He suffered and died to make us whole. Sin remains in the world yet, until his second return. And as you continue to call humanity back, O Lord, to fellowship with you, we ask that you draw us closer to you. You suffered, you died this week, yet you rose gloriously and triumphantly. Bless all of those who teach your way for married couples to plan out their children. Bless those who teach natural family planning, particularly the doctors, all the troops that work for you. They're your hands and feet. And bless all couples who open their lives and fertility to your will. Bless all of our engaged couples that they may realize the beauty of their own selves and marriage and sexuality. Bless these talks and bless those who work in this very valuable ministry. Enable them to spread this knowledge far and wide. May we spread it through our eparchies and throughout the church to all people, that they may understand the beauty of God's creation. Bless us tonight as we learn more about natural family planning. And may the Holy Spirit lead our discussions and learning. And all we do, we praise and glorify you, O Father, Son, and Holy Spirit. Amen.
Amen. Thank you so much, Father. Thank you, Co-Bishop. So our speaker is not stranger to a few of us. We've known her from helping in different education programs. Dr. Angela Kristen completed her residency in family medicine and a geriatric medicine fellowship at the University of Rochester Medical Center. She completed a master's in theological studies from the John Paul II Institute for Studies on Marriage and Family. So faith and science, as you can see. Studies, so she, in an effort to bridge women's health gaps she identified in medical education, she designed her own fertility appreciation elective during residency that included a training in NaProTechnology at the St. Paul VI Institute in Omaha, Nebraska. Her commitment to offering a broad range of options to her patients continues to bear fruit. In 2020, she opened Gianna Medical of Central and Western New York, a small practice specializing in women's gynecological health and restorative reproductive medicine. She practices NaProTechnology and promotes fertility appreciation. And we're so honored and blessed to have you with us tonight, Dr. Angela Kristen, to share with us the best kept secrets of NaProTechnology that unfortunately a lot of women don't know about them. So without further ado, I'm going to make you the host, which I should have done already and I forgot. And by all means, if you want to share your screen, go for it.
Great. Okay, so be patient with me. I'm using a different system than my own. I'm actually in my office still at the university, so I may have some glitches. Hopefully things will go smoothly. But thank you so much for the warm welcome. It's amazing to be giving this talk, because it was 30 years ago that I heard Dr. Smith's talk, Contraception, Why Not? A friend of mine, she was a physical therapist. Her name is Heidi Giroux. She was also a Creighton practitioner. And she invited me over to watch or to listen to this talk. I think it was either cassette tape or it was a VHS tape or something, but we watched the talk, and I was so moved. I was a very just a naive 19-year-old, very secular college student. And it's no exaggeration to say that it changed my life. And then so I didn't go to medical school. I went to do a degree in theological studies. And I actually didn't start medical school until I was 35 years old. So the Lord made it very clear. That's another talk in and of itself, that I was supposed to be on this path. And it really is a dream come true. Like when I hear Maurice read that, my bio, because I just think, oh my goodness, this was such a desire of my heart, and the Lord brought it to fruition. So thanks be to God. All right, let me share my screen here. Attempt to, at least, to make some adjustments here.
We can see it.
Okay, I'm going to slip into slideshow
Yes.
view. So, sorry. Creative here.
Do you need help? What's the problem? We were able to see the slides when you put it on slide view.
Okay, I can keep it there. I'll have to. I won't have access to my notes, my speaker notes, but that's okay. I've done this a few times. Should be
The Holy
okay.
Spirit will do it. Yes.
Oh, I just keep messing this up. Let's see. No. Okay. So NaProTechnology, most of you know, is natural procreative technology, developed by Dr. Tom Hildress, and I'll say a few more things about that shortly. And we practice, doctors that practice NaProTechnology, we really believe in restorative reproductive medicine. And restorative reproductive medicine, as opposed to suppressive therapies that really only treat symptoms. There's a famous quote, and I'll just summarize it, that if you really want to treat a problem, if you think of it, the tree, you don't just shake the leaves, you actually want to go to the root. And so that's what we do with NaProTechnology. We really go to the root of pathology. But even more than that, we're educators. We really teach our patients and take a lot of pride in teaching our patients the beauty, the dignity of their body, and how their fertility is central to who they are. So there are several different methods that are available in terms of fertility appreciation or fertility awareness. The Creighton medical system really, it shines when it comes to fertility appreciation. And that's really what makes one of many things that makes this particular method stand out. You can see here all of the biomarkers, the lactation method, the calendar method, mucus-only methods like Creighton, mucus and temperature like symptothermal, or the Marquette model, which incorporates also urinary hormones. These in green actually represent evidence-based methods that are available to for teaching, but you'll notice here there are even more ways that women can learn. You see there's an asterisk by the Creighton model, there's an asterisk by FEM, and there's an asterisk by neofertility here. These are all methods that have medical protocols that clinicians like myself can follow in order to take care of patients. We use the chart as a diagnostic tool, and then based on what we learn from that diagnostic tool, the charting, the observation of the woman's signs of fertility, we can actually make a better diagnosis and come up with a better, more efficacious treatment plan. The Creighton model, really, I kind of like the way this slide is organized, because all of these methods really have their roots in the Creighton model and in Billings and in Creighton. And Creighton, again, really shines in terms of understanding, really incorporating the spiritual aspect of man with his bodily life as well. So, some of the methods may promote methods of abstaining or promote contraceptive methods that would be opposed to us as practitioners, but also some of our patients. So, but there's a certain trust that you can have in the Creighton model from both a faith perspective as well as a medical evidence base. So this is the father of the Creighton method. I love the story of Dr. Tom Hilgers. Back in 1968, Dr. Hilgers was a medical student, and it's too bad that I don't have access to my notes, because there's a beautiful quote in Humane Vitae, and this was another thing that was dropped into my hands when I was 19 years old, about the same time that I heard this taught by Dr. Smith. And it seems to have had the same effect on both of us, but for me, many years later. But Dr. Hilgers was an OB-GYN resident, and I can't remember actually, and Oleg might know, I can't remember if he was a resident or if he was actually a medical student, but either way, he read Humane Vitae. It's remarkable. He took it seriously. And there was a plea by Pope Paul VI in Humane Vitae to the men of science. And the plea was to do the hard work, to roll up your sleeves, to embrace the toil of learning how more about how our fertility is designed, so that we can better teach couples how to use these natural methods. So Dr. Hilgers really heard that call as a man of science, and that has resulted in both the Creighton medical system as well as NaProTechnology. So we owe him a great debt of gratitude for all that he's invested. He really has been his life's work, and it's such a beautiful gift to all of us. So in terms of how we use that chart as a diagnostic tool, or how we use fertility appreciation and the Creighton medical system in practice, we use it for general gynecologic care, to diagnose and treat chronic discharge, chronic infections, bacterial or yeast, irregular cycles. We can identify normal bleeding patterns, abnormal bleeding patterns, pelvic pain, premenstrual syndrome. During reproductive years, it's very helpful in terms of pre-pregnancy and really preparing young women for the growth of their families. I have several young women that come before, have come to the practice before getting married, and we discuss all of the concerns, the stresses that they have regarding their wedding day and after. And just recently, I had a young woman that came to me in the fall, and she was getting married in December. And she said, my fiance and I really would like a honeymoon baby. And we just want to make sure that my health is optimized, so that if that happens, that will have a lower risk of miscarriage and greater chance of carrying the baby to term, greater chance of a healthy pregnancy. And I warned her, I said, well, you really don't know what's on the horizon. But she ended up, she's 9 weeks pregnant now. And she was disappointed that she didn't get pregnant in December, but it happened very soon, which would be a dream for many of my patients. So pre-pregnancy, we can use NaProTechnology and Kraton to assess pre-pregnancy health, certainly to address issues of infertility. Most patients that come in that after having done in vitro fertilization that has failed, they actually don't have a diagnosis. Typically, they're told that they have unexplained infertility, which is extremely unsatisfying. Women want to know why. And so I think with restorative reproductive medicine, we take a great pride in being able to having the tools to figure out what the underlying diagnosis is, and then treating that so that they have hope. And also too, just giving them a chance to have peace of mind, knowing that someone has really worked with them and has sought, all the potential causes, has attempted to treat all the potential etiologies of infertility. Recurrent pregnancy is actually something that I see. It's almost half of my practice right now. I see a lot of recurrent pregnancy loss. Hormonal monitoring and support during pregnancy has become a large part of my practice. And then now I'm reading this going, wow, it's interesting looking at all these, because perimenopausal and menopausal hormonal support, there are a lot of women that are seeking a better way to go through perimenopause and to manage the perimenopausal transition. So NaProTechnology can assist with all of this. Are there any questions before I move on? Feel free to interrupt me.
Would it be okay I ask a question?
Yes,
Sure.
yes. The doctor is saying yes. Go for it.
Yeah. I have a niece who's already had a baby, and she's finding very difficult to conceive again for whatever reason, we don't know. Unfortunately, she's going through IVF, and could you help? Could you help somebody like that she just doesn't know why she's going? I mean, I don't really ask her,
Right.
but she had a baby. She already has a baby, but she just can't seem to be able to conceive again.
I find that most patients are like me. They want things yesterday. So, but absolutely, that's what we call secondary infertility, someone that's already had a successful pregnancy and is having trouble conceiving again. And so that's a very typical scenario that I would see in a patient in my practice.
Thank you.
I have a question.
Yes.
Yeah, Dr. Kristen, what's occurring? What causes where they lose the baby, and as you think more of the environment we live in, the chemicals, or what?
That's a challenging question. It's a great question, and one that's challenging to answer. I find that one reason is if women are charting their cycles, they have a very high degree of self-awareness. They really know what's happening in their cycles. And so I'm wondering if there are more miscarriages now, or if there's just a greater awareness early in pregnancy of an actual pregnancy. Whereas if someone is not charting, and if someone doesn't really have that self-awareness, they may miscarry and not even realize that they miscarried. They might just think that they're late, or they had a heavier period.
But is that process of miscarriage, you think it always has been there? We're just more cognitive of it?
Yeah, it definitely has always been there. I think, you know, there are some people that have concerns about the effect of the environment. We know that the number one cause of miscarriage is a genetic anomaly. So, you know, you know, whatever with the genetics or the DNA is incompatible with life, and so the natural course is miscarriage. But in other cases, you know, we can look for other possibilities. We need to rule out certain clotting disorders. We need to rule out you know, problems with you know, well, certainly from the cycle, what we can determine is if there are short luteal phases or luteal phase defects. Dr. Hildress has identified 4 types of luteal phase defect. And then we can also, we know a lot more about folliculogenesis, actually how we'll look at some other slides for this, how follicles are developed. And if you have a healthy follicle, you typically have a healthy corpus luteum. So, you know, I think we're a little smarter about how to manage or how to prevent recurrent miscarriage. At least I feel like with NaPro, we're really doing a good job of thinking that through. So I don't know if I answered your question or not, but.
Yes, you did. Thank you.
I know in mainstream medicine, their answer would be women are just more aware earlier of pregnancy, that the pregnancy tests are better and you can determine a positive pregnancy test earlier than in times past. So move on. So I love this concept of the ovarian continuum, because we know that this little baby, this is a 7-month gestation. We know that this little girl, at this point in her development, she has 7 million primordial follicles. So she has 7 million eggs in the earliest stages of development already in the ovary. By the time she's born, the newborn, she's gone from 7 million to 2 million. By the time she has her first period, she'll go from 2 million to 500,000. And she can expect during her reproductive years to have 750 ovulatory events if she has healthy ovulation. And then we know that eventually we start with the 7 million, and throughout our lifetime, there's this beautiful shedding to where eventually we reach menopause. And that's where we have ovarian quiescence. Everything's quiet in this stage. We've used all of our eggs. So we you know, with NaPro, we really treat this entire continuum, and we look at each patient in terms of where they are on this continuum. We see, we know that there are 4 vital signs in traditional mainstream medicine. We look at respiratory rate, we look at the heart rate, we check a person's basal body temperature, which is a measure of their metabolic rate, and then also their blood pressure. But with restorative reproductive medicine, we know that there's a really important 5th vital sign, and that's fertility. A healthy ovulation, healthy menses and healthy ovulation is a vital sign. It's a sign of good health. And for men, healthy sperm production, spermatogenesis, that's another sign of good health. So it's really paying attention again to the whole person and that ovarian continuum for the woman. Normal cycle parameters. We know that, you know, it's really important to figure out what's normal and what's abnormal to be able to make the distinction and to be able to educate patients about this. We know that it takes 5 years for a woman's cycle to normalize. So starting from from menarche, from that first period, she could be a little irregular and have some changes in her cycle. And that's going to be normal as her hormones start to develop, start to to be released, produced, and released on a regular cycle. Cycles vary. The average length can be 25 to 31 days. Actually, that's not correct. I think that should be 21 to 35 days. Menses can be 4 to 7 days long. Actually, even in some cases, 2 or 3 days can be normal. Mucus cycle, 5 to 8 days. We need a stable post-peak phase that's 8 to 16 days in length. And then 1 to 3 days of PMS, again, can be normal. These are all parameters that we glean from the chart of someone that is using the Creighton model system. Abnormal would be not getting your period. We know that if you're not getting a regular cycle, again, if you're not ovulating regularly, it's a 5th vital sign. That's abnormal. Painful periods point to pathology. That is not normal. I have patients that for 10, 15 years, they've either missed 1, 2, or 3 days of work or school their entire, since Menarche, since high school, junior high, into college, and they think that that's normal. So I'm always so happy to tell them, no, that's not normal, and let's do something about it. Very irregular cycles. Some women have, 3, 4 periods a year. And again, they think that maybe that's unhealthy, but they're not sure. So we reassure them, no, let's get you in, let's figure out what's happening. What is the underlying cause? Very heavy bleeding, severe pain, and then PMS greater than 3 days prior to menses can be a sign of pathology. So here we have the normal parameters of the female cycle. Early in the cycle as the follicle, I'll stop here and just introduce you to this very busy slide. So we have 5 rows. We have the pituitary hormones in the brain, luteinizing hormone, and follicle stimulating hormone. We have ovarian changes at the level of the ovary. So we're seeing one follicle grow and develop. We see ovulation occur, and then the development of that same tissue of the follicle develops into the corpus luteum. Again, we have the hormones that are being secreted by the ovaries with the estradiol and the progesterone. On this line, we're at the level of the uterus. So we're looking at the lining of the uterus, and we're looking at the opening, the entrance of the uterus, which is the cervix. And so we're going to follow the effects of these hormones on the uterus. And then we have cervical mucus and what's called the Spin-Barkete. It's the measure of the stretch. And as in Creighton, the Creighton medical system, we use the Spin-Barkete. We teach women how to measure the stretch, how to observe for how to make basic observations regarding the quality and the character of their mucus. So let's tie this all together. So from the brain, early in the cycle, let's say conventionally, cycle day 1 is the first day of a woman's period. So she's shedding this endometrial lining. At that place in the cycle, pituitary hormones are low, as are ovarian hormones. And then as this follicle starts to grow and develop, this follicle starts to release this hormone, estradiol. As the follicle grows, the amount of estradiol in the bloodstream is proportional to the size of the follicle. So here we see the follicle getting larger, and we see estradiol rising. Eventually, this estradiol reaches a threshold. It's going to reach a threshold level, and that's going to signal to the brain to release luteinizing hormone. So it will release a surge of luteinizing hormone. The luteinizing hormone actually attaches to receptors on the outside of this follicle, and that's what causes a cascade of reactions that lead to rupture of the follicle and ovulation. So here we have the actual egg. Going back, as that estradiol is rising, it's also acting on the lining of the uterus, and it's thickening after you've shed the lining. You have a very thin lining after you've had a bleed. Now it's thin, but the estradiol is again causing proliferation of that endometrium, and it's growing. It's also acting on the cervix. So this glandular tissue in the cervix, I always tell patients, and they always giggle, because I tell them, this is like, think about your nose. You know, we all know that we have things that drain from the nose. It's glandular tissue in the nose that produces mucus. Okay, so we've all had a runny nose. Well, your cervix is glandular tissue, and it produces this mucus as well. But this one has a very important and very unique role. So estradiol is acting on those glandular cells, and it's secreting this mucus that the women will be able to observe through the help of their Creighton model, their Creighton medical system practitioner. They'll be able to make those observations and chart their cycle. So back to here, we are at ovulation. Here we have peak estradiol levels. We have that luteinizing hormone surge. And then the same after the egg leaves, this very important tissue of the follicle goes on to develop into the corpus luteum. And the corpus luteum continues to secrete the estradiol, but much more progesterone. Progesterone, the progestational hormone, is the predominant hormone of this luteal phase. So we know that this progestational hormone, progesterone, acts on the lining of the uterus. It actually, now you've had the thickening of the blood cells by the estradiol. Here you're going to develop a structural matrix. It starts a process called angiogenesis, which is the development of a capillary of blood vessels, all with the idea of if a baby is conceived and travels through the fallopian tube and embeds into the lining of the uterus, that lining is going to nourish that embryo in development until the 8th or 9th week of pregnancy. It's not until the 8th or 9th week of pregnancy that the placenta actually takes over as the primary source of progesterone. Up until that point, the corpus luteum is the primary source of progesterone. Now, if no conception occurs, the corpus luteum atrophies, the hormones decline, and we start a new cycle by shedding the lining of the uterus. Okay, and then we can also, go back to the cervix here, and we see the cervical discharge, and we see again just the rise in stretch as we reach this estradiol peak. We have lots of peak type mucus that we know that is critical for conception, sperm survival, and conception. Okay, so here again we have a schematic from of one ovary, and again you're seeing that those primordial follicles here, we are seeing it developing. This is the genetic material, the ovum. Again, estradiol is being released by that follicle, and then after ovulation, here you have the corpus luteum, and its primary hormone is progesterone, but we know it also continues to release estradiol. So just moving forward a bit, again, we thanks to the work of Dr. Hildress and the St. Paul VI Center, we do have standard levels of both estrogen and progesterone that have been derived from thousands of patients that have been under the care of the Paul VI Center. Those levels help us to know what's normal and what's not, and so we can actually send women for basic hormone profiles, determine if hormones are adequate or inadequate, and then supplement based on what that specific patient needs. This actually is just a summary of some research. Peak day, it's really important that, especially because of the proliferation of different methods of teaching women to chart their cycles, it's really important that they know that cervical mucus as a biomarker of fertility is extremely accurate. We know that 97% of women, and I've heard upwards of 99% of women, but 97% of women are going to ovulate within a 72-hour window of their peak day. So a lot of times if a patient comes in and I'll say, I want you to define for me what your peak day is, they might point to their peak day on their chart. Well, tell me what that signifies for you. And I really need them to know that peak day is not the day they ovulate. And that's typically what they answer. They need to know that peak day indicates a window of fertility. If this was, most women in this case, you can see here that many women in this particular study, it looks like between like maybe 32.5, 33% did ovulate within or on their peak day. Okay, but you can also see a wide range of variance here within 72 hours. There were some outliers, and I think that's that 3%. The 3% outliers are here, but the vast majority of women ovulate within 72 hours of that peak mucus sign. And again, just seeing the effects of progesterone and estradiol on the lining. Here's that thickening of the lining by estradiol, and then the angiogenesis and that structural matrix that's produced within the lining by progesterone. This is Dr. Eric Odelblad discovered the biological valve. And it's just this notion that the estradiol is when estradiol is rich, it does produce this estrogen type E mucus. You can see these channels in the mucus. In terms of visualization, it has that white, clear, raw egg white-like appearance. It's low in leukocytes, so it actually promotes the life of the sperm. And it's easy for the sperm to make their way because of the cervical fluid through the cervical canal, through the uterus, make their long journey all the way, typically out to the fallopian tube, the proximal end of the fallopian tube, where conception typically takes place. Here you have progesterone. Progesterone acts, this is progesterone-rich mucus. Progesterone acts as a desiccant. Think dehydration, because it pulls a lot of the fluid, the water out of the mucus. These cells are still producing something, but it's a thicker mucus, and actually this valve, this opening does close to disable sperm from actually passing through. So I'm going to skip this. So this is a slide that I go over with every patient that I see, just so they know that this is kind of the goal. This is a really beautiful cycle, and theirs probably won't look like this. But our goal in terms of treatment would be to try to get it as close to this as possible. Our goal is for them to have fullness of life and optimal health. Many of them come in with, wanting to have children, but I try to get them to focus on fullness of life and health so that they can fully live out their vocation. And if a baby comes, hallelujah, that's great. But the goal is optimizing their health. So you can see that the chart as a diagnostic tool can help us identify various patterns of abnormality. Here we have a chart with this particular patient. It's infertile. There is no cervical fluid cycle, so we would work that up. Miscarriage. In this particular cycle, she has a very short luteal phase. There's a very systematic way that we would review each of these cycles to determine, determine what's happening. This particular patient, she has some post some luteal phase premenstrual spotting, which could be secondary to low progesterone. I also ask her about pain in her cycle, because that can also be an indication of endometriosis. And then here in this particular cycle, you see all of these red stamps that indicate abnormal uterine bleeding. And so we definitely want to get to find the etiology of that bleeding. Modern infertility approaches, they test hormones on cycle day 3. I help teach a medical school elective on fertility appreciation, fertility awareness. And we, remind them, they all know, because they've all been through their rotations, that they're taught, they're trained that on cycle day 3, you send the patient for FSH and estradiol levels. Then on 22, you expect that you're going to be getting a peak +7 mid luteal phase reading, but there's no account taken for how long the patient's cycle is, where they've ovulated, and so this can often give you very misguided results. So our approach is, this is a typical targeted peri and post-ovulatory hormone profile. Patients are more than willing to go to the lab. Cycle day 3, I usually send them for a full hormone panel. And then pre-peak, they would do every other day estradiol, just to make sure remember that curve, make sure that we're getting a nice rise and fall of estradiol. And then for the post-peak phase, we would do every other day progesterone and estradiol, again, just to make sure that the progesterone is reaching adequate levels, that the length of the luteal phase is what it should be, and that the estradiol is reaching optimal levels. We know that many women with premenstrual dysphoric disorder have very low estradiol levels. So it's not necessarily low progesterone, but it's an unusually wide ratio between estradiol and progesterone. So that's another clinical clue or another diagnostic clue that we can get, and it does help guide our treatment. So I'm looking at the time, Maurice. Should I wrap up at this point?
I mean, if you're not done, that's okay. Melissa's with us, but if you have more to say, Dr. Angela, Kristen, by all means.
Okay.
Thank you.
Let me just stop at this point and ask if there are any questions.
I know I have someone. Okay, Mercedes raised her hand. So Mercedes, can you unmute yourself, please, and ask your question?
Sure. I guess a couple of questions I would have would be like, for people who have polycystic ovarian syndrome or issues with their thyroid, does this make it even more difficult? Or even, I guess, I know that like PCOS is like considered or called like the diabetes of the ovaries, even if people, and they're susceptible to developing diabetes. They're at a higher risk of developing diabetes. So I guess like people who have those kind of medical conditions, how much more difficult is it for them to I guess get a healthy cycle?
Well, I love working with PCOS patients. I would say, I mean, I definitely want them to come, because with PCOS, we can start working on those underlying, on the underlying pathology, so that we decrease their risk factors. Because of they have increased risk of diabetes mellitus type 2, they have increased cardiovascular risks. They have, because they have less periods, sometimes they'll develop endometrial hyperplasia, which can be a precancerous lesion. So, there are lots of reasons why they should be coming to a NaPro doctor for support. regardless of their reproductive goals, again, that PCOS patients are a perfect example of someone that I would be saying, listen, let's partner together. Let's work on restoring your health, optimizing your health, and normalizing your cycle. It's not going to happen on its own. So we need to get to work. And there are strategies, there are protocols and treatment plans. And different types of PCOS. There are 4 different phenotypes of PCOS. 20 years ago, we thought it was someone that was overweight, that had very obvious, hyperandrogenism, or where they had facial hair or cystic acne. Maybe they would have something called the acanthosis nigrans, the darkening of the skin of the shoulder or the axilla. Now we know that we have very, very thin, very healthy women that exercise regularly and eat very well, but they have genetic predisposition to PCOS because of testosterone exposure in the wombs of their mother, who probably had PCOS as well. So we're learning great things about PCOS. So there's lots of hope for women with PCOS.
Thank you.
We have a few questions in the chat. What can make a healthy young woman not genitally active have delayed period or no period for a few months? What can be some of the reasons that can cause anovulatory states, basically?
Yeah, so some of that could be, I would be concerned about. I mean, if I'm developing a differential diagnosis, one of the concerns would be, this we call the female athlete triad. So it could be, is she, I would want to know about her lifestyle. Is she exercising a lot? Is she food restricting? Is she a perfectionist? Is she extremely conscientious about her grades? Because we know that that stress and things that affect the mind can actually suppress ovulation. Again, I'd want to know about her family history. Does she have a history of PCOS? Yeah, I mean, I think there would be a lot of information that we would need to elicit from the patient.
Yeah, I'll ask 2 more questions in the chat, doctor, and then we'll ask the rest after Melissa's talk, if you don't mind.
That's fine. No, that's fine.
Is there a natural treatment for ovarian cyst?
Progesterone. Yeah, progesterone is an excellent treatment for ovarian cysts. You want to use natural progesterone. You never want to use a progestin like medroxyprogesterone acetate or levonorgestrel. But definitely there are protocols that have been developed through NaPro for the treatment of ovarian cysts. And then too, just, I would want to work with a patient on a regular basis to find out why they're making ovarian cysts. And again, looking at the underlying cause, not just treatment of the cyst, but to figure out why are they making these cysts, and to treat the underlying hormone derangement.
Thank you. Can a woman have 3 to 4 cycles per year with normal hormonal levels?
Unlikely.
Okay.
Very unlikely. Yeah. Maybe if she's nursing, if she has some type of disruption to the hormone, then to her hormones, then yes, but not normally, not in a normal state.
Thank you, doctor. And I'm sure there will be more questions. There is at least one more in the chat, but we'll just, for the sake of time, we'll give time for Melissa to give her presentation, and then we'll take questions related to NaProTechnology and to Melissa's talk in a few minutes. I'm gonna introduce Melissa, who used to be one of my students that I supervise in the Rochester, and you know her, Dr. Melissa, Dr. Kristen. You were in that program in Rochester.
I do.
August 2020, yes. So Melissa Tablada has been married for 6 years. She's a mother of 2 little ones. She has a boy and a girl. She lives in Miami, Florida. She's a licensed marriage and family therapist, as well as a Creighton fertility care practitioner, Creighton model fertility care practitioner. Melissa integrates the Catholic faith in her work as a therapist and fertility care practitioner. She is passionate about helping individuals and couples live healthy and holy lives in every way. And I have to admit, I've learned so much from Melissa. I learned from her how to use Instagram. She's been very helpful for me. And when we had EP2 in Rochester, we gave her actually one evening, 1 hour to teach us how to use Instagram. She's very active on Instagram, and you can connect with her on Instagram.com, Melissa Grace Tablada. She really has a great post related to family, to marriage, and it's always enriching to see what she posts there. And tonight's Melissa's talk is actually a continuation for what Anne started 2 weeks ago. It's charting your cycle's benefits for your marriage. So Melissa, I made you co-host. If you want to share your screen, I'm not sure, but the floor is yours. You can start.
Thank you, Maurice. I'm so excited to be here and chat with you guys. All right, let me see how I look at all my screens at the same time. Hold on 1 second. Okay, that's good. You guys can see that, right? My screen.
Yes, we can see it, Melissa.
Okay, perfect. Okay. So yeah, thank you for having me. I'm a licensed marriage and family therapist, and a Creighton fertility care practitioner, and they blend together so beautifully. I'm often having conversations with clients, with Creighton clients, about their marriages, of course, and I'm having therapy conversations about cycle charting and the need for it if they're not already using it. So there's a ton of overlap, and it's really beautiful to be able to serve my clients in all of these different ways. So tonight I'm going to be talking specifically about the marital benefits of cycle charting. And so we're going to talk about two things. One first being the research-based benefits of using a natural method of family planning on couples, for couples specifically. And then the second is how to achieve greater levels of intimacy in marriage, which both make me super excited, and I love talking about all of it. So these are some of the research-based benefits of using natural family planning for couples. And some of these, I'm sure, are very familiar for many of you, but I'm going to talk about details for each of these before we move into intimacy. So number one, avoiding pregnancy accurately. This is really important for couples to be able to achieve their goals for family planning successfully. And they can do that with something like Creighton, which is 99.5% effective, the method effectiveness rate. Achieving pregnancy successfully. So when the couple is ready to achieve pregnancy, 98% of couples are able to achieve pregnancy successfully within the first 6 cycles of trying, who have normal fertility. Able to successfully monitor your reproductive health, which is super important because we are, as human beings, integrated persons. And so every area of our health impacts the other areas of our health. And so if we have physical health issues or reproductive health issues, it's going to impact our emotional health, our mental health, and our relational health. Everything impacts itself. So if one thing is unaddressed, if we're not addressing reproductive health issues, it's going to impact the relationship, the couple, the marriage, and the whole family. We need to take care of ourselves as a whole instead of looking at each individual segment and just trying to take care of each little piece as if it's individual, as if we're not all completely connected. Another research-based benefit, we're able to treat the root cause of infertility and miscarriage. So by using Creighton, couples who are struggling with infertility have a 20 to 40% chance of achieving pregnancy. And then with the assistance of NaProTechnology, which is such a gift, up to 80% of couples are able to achieve pregnancy after struggling with infertility. This is a category that my husband and I fall into. We were struggling with infertility, charting, started working with a NaPro doctor, and was able to identify, treat the root cause of our infertility, and now, thank God, have 2 healthy pregnancies and children. And then looking more at like the dynamic of the couple, the impact on the couple, using a natural method of family planning increases communication, which makes sense when you think about it. If somebody is on the pill, it doesn't require conversations to be happening very frequently, whereas with cycle charting, we're actively having open dialogue. It could be daily about what are our family planning intentions, what am I observing about our health, about my cycle, where are we in the cycle, and so much more. It just allows and encourages an ongoing conversation and opens the door to increased communication. Greater intimacy. So couples who are using a natural method of family planning have greater levels of intimacy, statistically feel more connected. And so Creighton specifically has this acronym called SPICE, which I'll talk about in a minute. And I'm sure many of you are familiar with SPICE already, but it's one of my favorite tools. I use it with my therapy couples all the time, whether or not they're using Creighton. If they're using Creighton, just an added benefit, they're already familiar with it, but it's so practical and so helpful. So we'll talk about that in just a minute. And then most incredibly, maybe the lower divorce rate. Research shows that couples who are using a natural method of family planning have a 58% lower chance of divorce than couples who don't. And of course, there are many factors that go into this. It's not causal. It's not using NFP will remove your chances of divorce, but it's a statistic that's very significant, decreasing that risk of divorce by over 58%. So it's something that shouldn't be taken lightly or ignored. Very important. Okay, so when we talk about SPICE, this is an acronym that's looking at intimacy in its wholeness. Intimacy does not start in the bedroom. Sex within marriage as a form of intimacy is beautiful and important, but it's part of it. It's part of a puzzle that's much bigger and has many other parts to it that are equally important. And there's 5 key aspects to intimacy in marriage when we look at SPICE. And so we'll talk about each of them, but this is a super incredibly practical and effective tool for couples who are desiring greater connection, however connected they are, whether a couple's feeling super disconnected and really needing to reconnect, or if you're feeling like we're in a great place and we just want to increase connection and increase intimacy and be even closer. This is so practical. There are many times in my own marriage, whenever my husband and I are feeling even a little bit disconnected or sometimes very disconnected, when we're like, sit down, let's go through each of these pillars with SPICE and talk about where are we strongest right now, where are we weakest, and where do we need to adjust things. It's just such a practical tool that I love so much. So S stands for spiritual, and this is the core that's going to keep our couples and ourselves within our own marriages healthy. Prayer is essential. Prayer as a couple is essential for healthy relationships. Prayer should be happening both individually and together, because with prayer, it requires vulnerability, trust, openness. And so that allows for unity and closeness and connection and intimacy within marriage. There's many marital benefits to praying together as a couple. In addition to increasing intimacy in marriage, praying together, research shows, helps couples form a deeper connection, breaks down walls, improves communication, builds empathy and humility, strengthens faith, brings both closer to God together, and leads to greater levels of unconditional love. So an incredible amount of benefits for praying together in marriage. One study that was published in the Journal of Family Psychology found that couples who prayed together reported higher levels of marital satisfaction and commitment than couples who did not pray together. And another study that was published in the Journal of Marital and Family Therapy found that couples who prayed together are more likely to resolve conflict in a constructive way. And imagine if you're in conflict with your spouse and struggling to communicate and struggling to make progress and hear each other and come up with a solution, when the couple is more likely to turn to prayer and say, we're not getting anywhere. Let's pause. Let's pray. Let's ask the Lord to show us what to do and how to communicate effectively and how to hear each other and how to love each other. It's going to help problem solving and conflict resolution significantly. Okay, so the P stands for physical. And intimacy through physical connection is essential. on our best days in marriage and the worst days in marriage, when we really don't feel like it, we need physical contact and physical intimacy for the good of the marriage. And there are two different types of physical connection that we can have, and they're both important. One being arousal touch and one being affirming touch. So arousal touch is anything that leads to arousal. That could include sex, include anything that leads to sex. For couples, this is important. This is really important. When I intake a new therapy couple, part of that intake form is how often is intercourse happening within marriage, and how satisfied are they with that frequency, with the quality of their physical connection through the marital act. And those questions are really important and really revealing. Everything's connected. All of these different areas of intimacy help support the other. So when physical intimacy is lacking, when sex within marriage is lacking, many times a lot of these other pillars of intimacy are also lacking. And we can kind of address this from, it's a multidimensional approach. So we can address it in any direction and it's going to support the whole, but it's important to look at the whole picture and see where we're connected and where we're disconnected and what area needs a little bit more love. So if sex is not happening regularly in a marriage, it's something that should be addressed, should be talked about, because having sex within marriage is renewing our marriage vows, is making flesh, like a physical action of our marriage vows. We're physically living out that vow and reaffirming that vow. And so as much as the temptation is strong to have sex before marriage or outside of marriage, the temptation can become sometimes even stronger to stop having sex or decrease the amount of time or the frequency of sex within marriage. But that's just a trap and a lie of the enemy, because we need it. It's good and beautiful and going to increase intimacy within marriage. We should talk about what's good, what's helpful, what we like, what turns someone on within marriage, what doesn't feel right, what feels disconnecting or disrespectful maybe. Having those conversations is really important. Sometimes there's a problematic loop where women are desiring and needing to feel emotionally connected before physically connecting. And sometimes men are needing to feel physically connected in order to feel, or in order to be emotionally open and intimate. And so we can't wait for that other need to be met before stepping towards each other to meet these other needs. They're all important. So we don't want to wait to feel emotionally connected. The emotional safety is important. I don't mean safety, but we shouldn't wait for, like, I need this from you before I'll be able to give this. We all need it, regardless of how important it feels on a scale of different types of intimacy. If there are barriers to sexual intimacy, we need to talk about them openly and come up with a game plan to addressing them. And then affirming touch, on the other hand, so there are times, seasons, whether short, maybe a couple is charting with Creighton and there's the window of fertility and it's very important for them to be avoiding pregnancy at that time. So they're going to be avoiding intercourse during that fertile window. Other times, maybe there's illnesses or recovery from childbirth, or for whatever other reason, couples are going to be avoiding having intercourse at certain seasons and certain times of life. And so it's important that physical connection, physical intimacy is still present even during those times. So then we want to focus on affirming touch. This is a type of physical intimacy that communicates love, care, and connection without the intention to arouse, without those erotic aspects of touch that are beautiful and important, but not at all times. So some examples would be maybe a back massage or a foot massage, a kiss on the forehead, rubbing a spouse's legs or playing with their hair. That's like, for me, physical touch is one of my love languages. And if my husband will just play with my hair, like, I'm in heaven. That's like the best. Holding hands, cuddling, touching the arm or the back, a long hug, a long, meaningful hug is so connecting, so unifying within marriage. So never underestimate those affirming touches. And sometimes even a kiss. Couples can go days and sometimes weeks and longer without something as simple as a kiss. So we need those physical connections. I stands for intellectual. So there's a book that I love and recommend to everyone. called Boundaries in Marriage. It's by Dr. Henry Cloud and John Townsend. Excellent. They have a whole series on boundaries for different applications. Boundaries in Marriage, I especially loved. And one of the core tenets of holiness in marriage that they talk about is a zeal for personal growth and development. And I think that's really important because we need to have that. We need to always be desiring to grow and learn and improve, not in a way where we're like dissatisfied or feeling like we're not enough, but just because there's something so good and beautiful about knowing that there's more to learn and knowing that I can always improve myself in certain ways out of love for my spouse, my family, my friends, my work, my clients, whoever. So consider that. Is that zeal for personal growth present in you, in your home, in your marriage? We can consider the need to grow in our role as a spouse. We can assess what that looks like. How can I grow? How can I be a better husband or a better wife? How can I grow in my vocation? Intellectual can also look like just sharing what we're learning with our spouse. So if I'm learning something in the news, I don't like the news. It's mostly depressing, so I don't keep up with the news, but my husband loves keeping up with the news. So I'll ask him, like, what are you learning in the news? What should I know about? What do I need to be informed about? And that's a form of intellectual connection, intellectual intimacy, to have an interest in what is it that's going on in your mind? What are you learning about? We could share things that we're learning at work, in our vocation, from friends. Just what did you learn in your life? We should always be learning and growing, and sharing that with each other is beautiful. And we can also learn something together. Maybe couples take a class together and learn a new skill together, learn to cook together, come to Creighton classes together. Lots of things to learn together as a couple. C stands for both communicative and creative. I'm going to just focus on the communication aspect because there's so much we could talk about with both of them. So often married couples just get stuck in the day-to-day, like what's for dinner, what kid needs to be picked up where and when, I need your help with this, can you take care of this bill, can you help me clean the attic, whatever, please, I need time to do this, what's happening with the budget and the credit cards, and we're just caught up talking in the day-to-day. And all of those things are important and they need to be discussed, but we also need to talk beyond that. We need to talk about what are the past, present, and future joys of our life. When was the last time a couple reminisced and watched videos from when they were dating, or from the wedding, or from the honeymoon, or just reminisce on the honeymoon? Where did we go and what do you remember and what did we eat? Talk about the first date, talk about these beautiful moments from the relationship that many years later maybe are not talked about so often. When was the first time that the couple said, I love you? And these other beautiful moments to think about and think back to the beginning of the relationship, or maybe more recent moments from the relationship. Thinking about, those joys, reminiscing on the past, and also sharing current stresses and concerns and things like that too, just communicating openly. So we can do that in many ways, dreaming together, discussing goals, thinking about like what kind of conversations did we have when we were originally trying to get to know each other, and originally trying to get to know each other and pursue one another. Because what happens, so coming from a marriage therapy lens, we need to have a love map built mentally, emotionally, spiritually of our spouse. And we are always constantly growing and changing over time. Think about how much you have personally grown and changed over the last 10 years. And if you have this idea that your spouse is the same person that they were when you met them, and that was a number of years ago, they're not the same person. They've grown, they've changed, and it's important that we continue, like, you know how Apple Maps in your phone or any GPS is constantly being updated because there's new roads forming and there's new stop signs and there's all these new developments happening with a map. We need to constantly be updating the maps that we have of who is our spouse, what's happening internally, who are they? And so that happens, a huge part of that happens through communication and through continuing to engage in the type of conversations and the depth of conversations that maybe were had more commonly in the beginning of the relationship. And lastly, the E in SPICE stands for emotional. So one way to build emotional intimacy is by sharing what's on your heart, whether that's good things that are on your heart that you're thinking about. What are you pondering? What are you considering? What are you stressed by? So it could be good, it could be harder things, everything in between. Each person is responsible for their sharing, for being open, and for inviting their spouse into their mind and heart. Then it's also, so that's my responsibility, is to share. It's also my responsibility how I respond to my spouse. So how we each respond. And that's a huge important part of it, because the response needs to be supportive and encouraging when one spouse is opening up and sharing. If the response is not supportive or encouraging, that's going to be a huge barrier to connection in an emotional way. So look at yourself first. It's really easy to look at the spouse, look at what the spouse is doing wrong and how they're responding poorly. But look at yourself first when a spouse shares something, anything with you, no matter how big or small, how pleasant or unpleasant. What's the tone that you respond with? What words do you respond with? What is your body language? Does it feel safe? If you were on the other side of your reaction, your response, does it feel safe and inviting for the other person to continue opening up to you? Something that we can do to practice improving emotional intimacy is active listening and validation. People struggle generally with validation. I'll talk about active listening first. Okay, active listening is not listening with the mindset of, I'm going to respond and give them a solution as soon as they stop talking. Active listening is, I'm listening for the sake of understanding the heart of my spouse. I want to know them. I want to understand how they're feeling. I want to ask questions to understand better. I want to clarify and summarize what I hear to make sure I understood correctly and accurately, because I'm going to hear anything that's said through my own experiences, through the lens of my perceptions and how I see the world. But spouses see the world often very differently, sometimes in a totally opposite way. So if I'm not listening actively to try to understand, what are you telling me? What do you want to communicate to me? How can I hear you and know you and understand you? I probably need to ask questions. I probably need to check in and make sure I heard and understood correctly, because we can all see things in a different way and hear things in a different way. We don't want to jump into offering solutions or trying to make things better. Even with good intentions, often couples can minimize and create a barrier to emotional connection when we say, like, it's okay, everything's going to be okay. That can minimize and just dismiss how the person is feeling if they're struggling with something. So validation doesn't mean I agree, doesn't mean I even understand. It doesn't mean that the person is right in how they think or feel. It just means that you're giving them permission to feel however they feel, and you're holding space for that feeling. And so it might sound like, I hear that you're feeling really frustrated about that. Tell me more. That's validating. You're validating that they're allowed to feel frustrated. You're making space for that. And the ability to validate within marriage, within anyone, with any relationship, is going to allow for emotional intimacy to exist. So those are just a few thoughts on how we can use SPICE in a really practical way to increase the connection and intimacy within marriage, in addition to some of the research-based benefits of practicing a family planning method on the marriage. Highly recommend it. Personally, professionally, from the therapy lens, from the Creighton lens, from my own lens, incredibly helpful. It's not all rainbows and butterflies. It's not always easy and perfect and beautiful, but the benefits are significantly worth it.
Thank you so much, Melissa. Thank you. It was a blessing tonight to be given two great talks with Dr. Kristen and with you about NaPro and about the benefits for marriage. So if there are any questions for Melissa, even for Dr. Kristen, we can take them from the people before I ask the questions that were sent to me, that were given to me. So anyone watching who has any question, I know there was one question also put in the chat. So yeah, I'll ask all of these in a few minutes once we just give chance for people to ask directly Melissa or Dr. Kristen. Melissa, from your experience as a family therapist and as a Creighton, do you have couples who, because of spice, they change their perception of Creighton, where they might be coming in with like, we can't do this, it's really hard, how can we avoid having intercourse on those days? Like a lot of people, especially who have been using birth control pill, sex on demand, they find it like it's impossible to use natural method. So from your experience with dealing with couples like that, have you noticed that once they start learning different ways of interacting with each other, they become more open to that and more willing to embrace it?
Yeah, I would say more from my experience with my clients in therapy, because I would say most of my Creighton clients are like newlyweds who weren't sexually active before.
Okay.
So it's like not exactly the same experience, but a lot of my therapy clients who are having trouble because then, right, they're coming to therapy because they're having trouble connecting or they're struggling in their marriage. And so then whether I'm like reminding them, because sometimes my couples like maybe learned Creighton 15 years ago, but haven't really looked at it or used it since. And it's a barrier to their connection, to their intimacy, for various reasons. So it's definitely, yeah, helpful to the overall intimacy, the ability to practice Creighton well. And it's interesting because I feel like people at first glance, when I talk about it with Creighton clients, I would say a lot of people, my single women who are not married yet are like, this is amazing and I can't wait to practice it. But I feel like a lot of times couples find it cheesy, especially if they're feeling connected already. If they're feeling well connected at that moment, they find it kind of cheesy. And so I give a lot of examples and share stories from my own experience with other couples, how practical and how useful it is, and things that seem so simple, like, okay, yeah, emotional connection, physical connection, great, seems like maybe too simple or too cheesy or whatever, but it's so practical and it's like, yeah, so simple that, but are we doing it? Are we using it? Are we connecting in all these ways? Or are we just like going along hoping that we're connected and then one day finding ourselves disconnected? So it's very practical and helpful.
Yeah, thank you. I liked a lot when you mentioned that in your own relationship, how you sit together and try to see where is the strongest, where is the weakest area, and how much this is needed to really, because we have to live our intimacy, sexuality in its all dimension. It's a whole. It's not just focusing on one aspect. And I think that's why, unfortunately, so many marriages are failing, because they end up focusing just on the physical part and they don't realize it's all connected.
Yeah, I find this really practical too for postpartum couples. It's that this past year has been the most common struggle I'm hearing with my clients across the board, both Creighton and therapy and coaching, and everybody who's talking to me is feeling extremely disconnected after the birth of a new baby, which especially a first baby, sometimes other babies too, but it's just such a huge transition, and couples kind of forget like how to operate when they're with a newborn, and they forget how to connect with each other, and there's so many new things to learn. And so this is such a practical tool for couples when they've had a new baby or just entering like a different season of life or more challenging season of life. Yeah, it's always good to go back to and reassess throughout different seasons.
And we have to mention that spice is a tool for self-care also. Single women can just use it to take care of themselves on all those different levels. So it's not just for intimacy within marriage.
Mm-hmm.
We'll continue to take questions for Melissa and Dr. Kristen. We have a question in the chat, Dr. Kristen, following up on what you said about natural progesterone used for treatment of ovarian cysts. Can you give examples of natural progesterone, please?
Well, it's micronized progesterone. If someone is experiencing, acute severe pain, you can do an injection, an intramuscular injection. Typically, it's 200 milligrams, or you can do 100 milligrams. It's intramuscular, and it's usually done in the one of the hips. So it can be uncomfortable. Some patients prefer to try. There is a commercially available progesterone called Prometrium, It's micronized progesterone. It's available in a capsule. And sometimes we can try the prometrium, or we could even try a compounded intramuscular, like just a vaginal suppository, to see if that resolves the cyst.
Okay, thank you. On that topic with the progesterone, can you speak a little bit about progesterone support during pregnancy? Is it something becoming you see more as a NaProTechnology medical consultant, or is it being used also with other doctors, or just NaPro?
Probably NaPro, but then also I know the two other Fem and NeoFertility, they both have protocols for progesterone support. I'm sorry, for pregnancy support, progesterone in pregnancy. It's in mainstream medicine, like when I was training and when I was actually delivering babies, no one agreed that you should use progesterone because they didn't feel like it had a strong enough evidence base. But when you start treating patients, and you see a high volume of patients, and I don't necessarily see a high volume in my practice, but I trained for a year with Dr. Ann Nolte in Gianna in the Gianna Center in Manhattan, but there she does have a very high volume of patients. You start to see the benefits. And so it was through NaPro, it was through the NaPro medical consultant training that I really became convinced that that progesterone was helpful. Yeah.
Thank you. Doctor, teenagers who's struggling with acne and is on birth control pill, what can NaPro do for her?
Well, she might be struggling with acne because of, well, first of all, with the birth control pill, certainly shutting down her natural hormone cycle and setting up an artificial one isn't a remedy. It's not it's not a good idea. And you're also typically you're using a combo pill of ethinyl estradiol, or a synthetic estradiol that's not bioidentical, and then a progestin, which could be harmful. So that's not ideal. I would say, look at the basic hormone panels, look at her diet, just look at her overall health. A lot of times the acne that we see, especially more so now because of obesity in younger people, I really just across the generations, I think we're seeing more cystic acne because of insulin resistance. So sometimes just tackling the insulin resistance. In fact, that's probably why, people think that girls are starting their periods younger and younger and younger, when actually they're probably having like insulin driven bleeding from the uterus. It's not a true period.
PMS, how can NaPro help? Because a lot of women these days suffer with PMS, but they just, as you mentioned, they just think it's something normal.
Yes. Well, first and foremost, before thinking about any treatment, what I talk to women about is just the natural hormone fluctuations in their cycle, okay? And charting raises your awareness of how those mood swings, how those changes correlate with your cycle. So I tell women that the most important time of their cycle is 1 week before they start start their periods in their luteal phase. They need to be exercising. They need to be, paying very close attention to their nutrition. They need to be paying attention to their prayer life. That is a really delicate and important phase of their cycle. It's the rare woman that has no PMS. I have had patients that have no issues with PMS at all. There are other times, though, whenever PMS is actually rooted in hormone derangements. So sometimes we can simply supplement progesterone at bedtime during the luteal phase if we've done a hormone profile and there's a need for that. Sometimes I do the hormone panels and the hormones are normal. I just want to mention that because that does happen. And then we work on. I send them I try to find a good counselor like Melissa, because usually they need some behavioral therapy that can be extremely healthy people get help. And then One of the best treatments for PMS, though, in the luteal phase, and especially when there is a luteal phase dysfunction, would be HCG. Some patients will do subcutaneous HCG injections. They're not painful. You do them every other day on peak plus 3, 5, 7, and 9. The HCG actually raises both estradiol and progesterone levels, and I've had excellent success with patients on HCG.
Thank you. This question came up in another session about menopause, hot flashes and other symptoms women struggle with. How can NaPro help women in those cases when they're no longer cycling to time any testing or anything that needs to be given to the woman?
Well, on that ovarian continuum, you know that you begin your perimenopausal period. It's typically around age 37, 38. And that period can last, that perimenopausal phase can last 10, 15 years. The average age of menopause or last menses would be 51 years old. So in that transition, your cycle is going to change a lot. Oftentimes, if typically through your reproductive years, your peak day has been on cycle day 19, it's not unusual for you to notice peak day on cycle day 12 or cycle day 9, periodic short cycles, some cycle irregularity. All of that is a part of the perimenopausal transition. So with perimenopause and menopause, you're losing estradiol. You're also losing androgens like testosterone, DHEA sulfate. I mean, there's a whole hormone profile that we do on cycle day 3, where we test for these hormones. We know that there are certain hormones that decline in this phase, and so it's very common for women to gain weight. And so there's insulin resistance that we develop as we move through our 40s and into our 50s. So we can start to tackle these things. The key, though, is doing the hormone panels and identifying the abnormal values.
And this can be done even if she's past cycling or very close to
Absolutely.
menopause.
Absolutely.
And it's still, okay, thank you. Painful period. How can someone reduce period pain?
So, probably the most common cause of painful cycles, it's going to be endometriosis. So what I typically do for patients with cycle pain, first of all, just characterize the severity of the pain, the location of the pain, just do a really good symptom profile of their pain, and then acknowledge it. And talk, I always want to find out, how that's affected their life. So I may be the first doctor that they've ever spoken with where that's actually been sympathetic. Not always, but or the first doctor that didn't just recommend an IUD or oral contraceptive pills. So what can we do in NaPro? First of all, we try to get them to recognize the pain and to treat the pain with anti-inflammatories, vitamin B, fish oil. There's a natural anti-inflammatory called pycnogenol. So I actually have a handout for my patients that I provide to them on the first visit. And I talk with them about medication, over-the-counter medication, as well as just therapeutic remedies. If I'm concerned about endometriosis, if they're not getting relief, I need to connect them to a NaPro surgeon. And I try not to go longer than 3 months. I have some patients, though, are very hesitant to go the surgical route. Unfortunately, in our area, we don't have NaPro surgeons, so it often involves travel. But I have built good relationships with one with Dr. Damian Olson in New Hampshire, with Dr. Nick Kangawasa in Atlanta, Georgia. I've set up surgical consultations with Dr. Young and Dr. Gavin Puthoff in St. Louis. And so trying to figure out ways to connect the patient to the surgeon and really explain to them why it's important that they see a NaPro surgeon and not just a traditionally trained obstetrician gynecologist. The rates of recurrence of endometriosis are much higher with the older techniques. The new surgical techniques that Dr. Hildress has developed have much lower rates of recurrence. And not even just Dr. Hildress. There are some special fellowships across the country that are developing, because it's such a huge problem, where people learn. Dr. Nick Kungawasa is a great example of this. He isn't actually one of the JP2 fellows from the Paul VI Center, but he is friends with all of the fellows and has operated with them and learned a lot of the techniques from them, and he's very well trusted. So,
Dr. Kristen, can you please in the chat put your contact information for people who would like to connect with you, and your address or your website? And the question is telehealth available for NaPro if there are none in the area?
yeah, that's the challenge. If you're within New York State, I can see you, but outside of New York State, you'd have to actually come to New York. They have to come to the office here, and I'd have to see you in person. And then after that, we could do telehealth, but it does involve, if you're out of state, it involves an in-person visit. But, there are great doctors and some much smarter than me in restorative reproductive medicine. So I could help connect you to someone that could provide care.
And I know mycatholicdoctors.com has a lot of trained NaProTechnology medical consultant, and they do telehealth also.
Absolutely. And don't forget about Dr. Ann Nolte in Manhattan. I mean,
Yes.
she's been she's a friend and a sister, and has been such a great professional mentor. There's no one, she's my doctor. So
Yeah.
when I trust more.
She was mine too when I lived in New York, and I worked at Gianna Center for some time. So Nicole and Rosa, Dr. Nolte would be the closest to you to connect, because you live in New York City. So she would be your connection, and I can share her information with you. Melissa, as a family marriage therapist, conflict resolution, what's your best advice for couple related to conflict resolution?
Well, I don't know if this is a good answer, but the first thing that comes to mind is that we need to learn how to communicate effectively. Like effective communication and connection, like the connection before. We can't resolve conflicts effectively if we're feeling completely disconnected. And we need to learn how to communicate effectively to be able to talk through conflict effectively and clearly, because what I see all the time in therapy sessions, especially, is I could listen to a couple for 30 minutes if I don't stop them bouncing back and forth between all of the things that they're upset about, that one thing leads to another thing, that we were fighting about this thing, and then I don't even know what they're fighting about by the end of 30 minutes. So it gets complicated, and without healthy communication skills, like really simple skills, but if we're not taught them and we don't practice them, we don't use them, we don't just magically know how to communicate effectively. So I have some like really go-to communication skills, but that is what I would say. I feel like that's maybe like not as specific as an answer as maybe somebody was looking for, but connection, like focusing on the connection first, making sure we're connected in all those areas of spice, not perfectly, but just working on increasing connection and communication skills so that when conflict comes up, we can resolve it effectively.
We have one more question in the chat, and I'm going to just answer it by putting the link to the fertilitycare.org website. And that's where you can find a medical consultant near you. I don't know how updated it is, but hopefully it is updated recently, and you would be able to find a NaPro doctor. But if you can, just connect with one of us, connect with me, with Melissa, with Anne, with Angela. We're all here to just help you to be able to connect with NaProTechnology and with the practitioners. Dr. Kristen and Melissa, it's almost 9:40, so we're gonna bring it to an end. Thank you so much. It was great having both of you here. And I will be sharing the recording, and you can just share it with other people. It was really great to hear all what you've shared with us and how important it is that we really spread this word more, like the importance of it for marriage, the importance of it for women's health, for her fertility, for the couple's fertility. Like this is so much needed, and we're not doing justice this topic. So hopefully we can do more to spread awareness, and hopefully we can even maybe, like Father Core Bishop suggested, maybe have an article in the Maronite Voice about it. So if we end up writing it, I'll share it with all of you, so you can just we can just be all on board and try as much as we can to spread the word and raise awareness. So thank you so much. I really appreciate your presence here. And we thank everyone who's been supporting us during this series. This actually concludes our series of 3 talks to celebrate Worldwide Fertility Care Week. I know Sister Therese was with us. Okay, I'm sorry, she left. I meant to welcome her and I didn't have a chance, but she's been also a great support. So we thank everyone, and we ask you to keep all of us in your prayers in this ministry, in this mission, because there's so much that needs to be done, and it's not easy to do it, but by God's grace, we can do a lot of things. Thank you so much.
Thank you all.
Thank you. God
Thank you.
bless. Have a
Thank
happy
you.
Holy Week, or
Thank you.
holy,
Yes, blessed Holy Week to
Holy Week.
everyone. Yes, yes.